So we're just, okay. So our task force was established in 2012, and we were asked to consider what is the core continuum of rehabilitative care services that are needed in a long-term care home, given the diversity of residents we're now seeing, residents with increased acuity of care needs, as well as how do we best serve residents with dementia in our new rehab model. So documentation and reporting issues related to the rehab and specialized therapies, we needed to look at what are the best directions or what are the key nuggets of information that people in the sector need. We also looked at what are the education needs around rehabilitative care, what's the difference between nursing rehab and restorative, how do we define those two, et cetera. And then we were also very active in providing some supporting documentation to the ministry around the reporting requirements for both physiotherapy as well as the exercise. We have a diverse membership on our group. We have homes, we have people from CIHI, people from the ministry, we have researchers. So when we all get around a table, there's quite a whole lot of dialogue happening and exchange of information and ideas and thoughts. And it really has been through that open dialogue and discussion that we've really come up with some great ideas, some great thoughts and as to how best to tackle this. So this is just some examples of the work that we've done to date. So there was a paper provided to the ministry on physiotherapy provision in long-term care, some issues and recommendations. And then we're also looking at some analysis of what's happened in the program and support services envelope with respect to exercise classes. One of the first things we did really early on in this task group was to look at what was our current state in long-term care with respect to physio services, rehabilitative care, nursing rehab, and then how does this all fit together. And right at the very beginning, before the change in August, we had a lot of physio services in our homes. A lot of our residents were receiving significant benefit from those physio services. We then had some form of a restorative program, nursing rehab program in place, and that was then augmented by our program and support services envelopes and the programs that they offered in the physical domains. We then looked at what were we moving to, or what would be the desired state if we were to have that magic wand and a little pixie dust. What would we ideally want? And we all know that under the Act and the regulations, we need this restorative philosophy of care, and that is very different than a restorative program. So if we were to implement a restorative philosophy, what were all the components that would in fact encompass? So we would want evidence-based programs. We have a lot of research and literature out there on best practices in the areas of fall, skin wound, continence, etc. We also would want our residents to have group exercise program. We would want some recreation therapy, recognizing that our care needed to encompass the whole person, not just physical. We would need a nursing rehab program, and then for those residents who had very specific targeted clinical needs, whether it be for improvement or to maintain their functional status because they have a degenerative condition, we would then also have and want PT, OT, SLP, and the psychosocial or the psychogeriatric supports that we need for the complex residents. Now I'm going to turn it over to Dale.
Thanks, Debbie. So how did we do this and what did we look at? We looked at a lot of considerations from the task group and all the brilliant minds that sat around that table. We looked at the admission, what does the consent look like, the interdisciplinary assessment to determine needs, what is the eligibility criteria to get in to any one of these programs, and looked at therapeutic goals, those targeted interventions that you absolutely do require. When it came to the treatment part of it, resident-specific care planning, doing the right thing for the resident. If you look at that resident and you say, what really do they need? Do they need physio? Do they need nursing rehab? And what are the criteria to get in? And providing the right treatment for the resident, that was key. Looking at that detailed interventions for residents, whether it's related to physio, OT, nursing rehab, restorative exercise programming. And also link the MDS outcomes. So you've heard from our panel that a lot of organizations have taken the MDS outcomes to look at how are we evaluating our residents. Are they getting better? Are we maintaining what their current abilities are? And making sure that's part of your course of treatment, what your interdisciplinary team looks at, and the plan of care. Discharge and transition plans. So there was a lot about discharging residents from physiotherapy. And we don't necessarily always see it as a discharge. It's actually a transition to possibly another area. They could be going to exercise. They could be going to a therapeutic program. They could be transitioned into nursing rehab. You can also transition back. So if a resident starts to decline once they've been removed out of physiotherapy, they actually may transition back into physio. And looking at all those pieces. And looking at the needs for maintenance. Maintenance is a key component of what we do. We don't want residents to decline in their ADLs. We want to maintain their current function or their maximum functional level. So how did we do this? There was a lot of literature research. We looked at the RIMDS, the outcome scores. We used our resources, our people, looking at the funding and what that was available and what could we do with the current funding that was being provided to us through the new model. And then ethical decision making, because it was ethical for a lot of homes. How do I take this off? How do I talk to the resident? How do I talk to the family? Look at those. Do we have wait lists? And who is going to be on the wait list for an exercise program or for physiotherapy? Looking at the documentation and reporting, there was a lot of discussion. There was a lot of models developed, working with the task force, the ministry, to help them understand how does physiotherapy exercise program work in long-term care, and how can we make it the best, and how do we document that appropriately and still provide the care and not do all our time on documentation. So the next steps, OLTCA, the members of the committee, we do sit on various committees, the definitions committee with the Alliance, in order to help inform decision-making that will go to the 14 LHINs as well as to the Ministry of Health. What does long-term care look like? And what are those definitions for physio, rehab, et cetera? And help make the right decisions as we move forward. There is a resource guide that the group has been developing, and this is on rehabilitative care, physio, nursing rehab, restorative, et cetera. That will be coming out shortly. We will be having another meeting early in March and look at the pre and post physio, the implications of what the policy did, as well as the survey results. So the survey results were survey was set out by the University of Waterloo, and what do those results show and what do they say? So we can actually have informed decisions as we move forward.